Hi, everyone, online, all over the world, come from lots of country. Good night. It's my honor to be a moderator again. I'm Dr. Wang Xiaoting, come from Beijing, China. I'm a ICU doctor. I worked Peking Uni Medical College Hospital, ICU. Uh, in the past week, Professor Zhu Ran and Professor Cao Yangong take two excellent lectures, respectively. About one is ultrasound images, features, and criteria for COVID-19 patients. And Professor Zhuran's topic is about the respiratory management and critical ultrasound for the COVID-19 patients. Tonight, they all are moderate, so it's my honor to invite them introduce themselves respectively. Please. Vice Zhuran, hi.
Hi. Good evening, dear colleague. This is Dr. Ran Zhu, or Dr. Zhu Ran, or Dr. Zhu, as you like. I'm an ICU attending from the first affiliated hospital of China Medical University. I was a speaker who gave the speech on Wednesday with the topic of respiratory management with critical ultrasound for COVID-19 patients. I'm happy to be here again. Thank you.
Okay,
Yeah.
I think now it's my turn. Hello.
Yeah, it's your turn.
I'm Dr. Yanggong Chao, as Director of Department of Critical Medicine, the first hospital of the Tsinghua University. And also I'm Executive Chairman of Chinese Critical Ultrasound Study Group, and also Deputy President of Beijing Research Association on Critical Ultrasound Ultrasonography, and also a trainer of CCUSG and Greenbox. Tonight, I think it's a very interesting topic from Dr. Yiman Hong. As Dr. Xiaoting introduced before, COVID-19 is mostly involved the respiratory system and also circulation system, especially in the critical care patients. So we sending or give some lectures, more focus on the first is image pathologies and also pathophysiologies. And then now is the clinical management and treatment. So the first is from Dr. Zhu Ran is respiratory management, and now from Dr. Yiman Hong. He is worked for this COVID-19 patients more than 50 days as a manager and secure a lot of patients. I think he has a lot of experience can give us, and I think it's very useful. Now I think now is Van Hong's turn.
Yeah. Professor Cao Yangong gave us lots of information about today's lecture performed by Professor Yiman Hong. Now it's my pleasure to invite Professor Yiman Hong take a lecture and introduce himself. Today his topic is critical ultrasound and circulatory management for severe and critical COVID-19 patients. Let's begin.
Hello, everyone. I'm Dr. Wang Hongyin from West China Hospital, Sichuan University in Chengdu, and also I'm a member of Chinese Critical Ultrasound Study Group that we call CCUSG. Today we'll give you the lecture about critical ultrasonography and circulatory management in critically ill COVID-19 patients. Firstly, I will give the apologies because I missed the first two lectures because of the emergency rescue in Wuhan, we have another COVID-19 patient. So I missed the first two lectures. Today we're focusing on the circulatory management of COVID-19. As we all know, COVID-19 has been outbreaks in all over the world, and there may be 30% or more patients were in a risk of bad outcome. So the hemodynamic therapy is very important in such severe patients. Firstly, let's review the basis of hemodynamics. As we all know, the blood return to the heart as a preload around the vessels, be pumped out to the aorta as a cardiac output. With the help of the vascular tone, they generate the blood pressure that drives the blood go forward to the organ as a tissue perfusion. If any damage happened to the hemodynamic, we got hemodynamic disorder. We divide the hemodynamic disorder into two types. The severe one is shock, which is characterized with deterioration of microcirculation and oxygen metabolism. And the second type is hemodynamic disorder without shock, including the vascular disorder, that is vasopressure and leakage, and the heart disorder that include the acute right heart dysfunction, the systolic and the diastolic dysfunction, and the cardiac disease or valve disease. The third is violent disturbance, include the fluid overload or fluid maldistribution, hyper or hypovolemia. This slide summarized the key points of the hemodynamic disorders to make you understand clearly. We can see there are many elements of hemodynamic disorders: the hypovolemia, fluid maldistribution, and the different types of heart function abnormalities, and the vascular insight, and the tissue perfusion deterioration. Firstly, we'll start with vascular insight. As we all know, the vessels keep the blood inlet without leakage. There are two important structures, that is endothelium and glycokinetics, that keeps the fluid in the vasculature. These pictures shows you the endothelium and glycokinetics and how the leakage. So if the diseases produce the inflammatory and the other insight, the leakage happened and the fluid overload could be seen in the severe patient. We're focusing on the respiratory system. why the lung is a key organ that the fluid maldistribution happened. There are three reasons, as we all know. Firstly is a big surface area of the alveoli. There are type 1 and type 2 epithelial cells, and the alveoli covered with parental capillary network. Also, they have endothelium and glycokinetics to keep the fluid in the vessel. And the third reason is there are huge blood flow in the lung because the flow of the whole body pass through the lung. So, knowing the reasons, we are not surprising about this research results that early risk factors and the role of food administration in developing acute respiratory distress syndrome in septic patients. We found the result that as the amount of fluid in the first 6 hours increased, the rate of ARDS increased either. Fortunately, we can see the result of the biopsy of the early stage COVID-19. The damage happened to the epithelial cell and the alveoli, and the vasculature and the endothelium is not damaged in the early stage. So the hypoxia is a key result of the early stage COVID-19 because damage happened to the alveoli, and the patient could not get enough oxygen. So there are acute severe respiratory failure. But as the disease progressed and as time goes by, the damage happened to the endothelium. So we can see in the later stage of COVID-19, the biopsy, we can see the damage happened and the vasculature broken, and the endothelium and the glycokinetics were damaged. So the leakage happened. So we can make a summary about the mechanism of COVID-19 in the two stages. Firstly, the epithelial cell damaged in the very early stage, and the hypoxia happened. The patient got respiratory failure and may be very, very severe. And as time goes by and as the diseases progressed, the damage extend to the vasculature and the endothelial cells, and the glycokinetics were damaged, and the vasculature were broken, and the leakage happened. That may be caused by the hypoxia itself, or the reaction of the hypoxia, or the inflammation, and may be caused by the disturbance of hemodynamics. So in the early stage, if we perform the lung ultrasound to the patient, because of the epithelial cell damage and interstitium, and heavily damaged and increased water in the interstitial tissues of the lung. We found B lines and we found ultrasonic non-interstitial syndrome, and we found subpleural small consolidation that corresponds with the biopsy in the early stage. And in the advanced stage, or we call the later stage, as the endothelial cells involved and the vasculature broken, the whole tissue of the lung were damaged. So, except for the hypoxia, the fluid linked out more and more, and the patient is more like ARDS. We see the sign of gravity gradient, and we see the water drops to the posterior part of the lung. The consolidation is commonly seen commonly found in the non-ultrasound findings. So that's a different. So we see that in the early stage, the patient, the respiratory failure is caused by the virus itself, but in the later stage, the respiratory failure is by the virus and the leakage and the pathophysiological changes of ARDS. That's very important. So this is chest CT and the non-ultrasound signs of the COVID-19 patient. We found in the later stage, as you see in the left picture, we see consolidation, we see many infiltrate and normal area of the lung, but in the right picture of the slide, the diffused interstitial exudation corresponds with CT. We found A lines and B lines and consolidation. These signs give you a clear picture what a patient happened to the pathophysiology of the lung. And what we learned from the work, there are signs that indicate the patient got more fluid leakage. If you see more consolidation, that means the worse endothelial injury. If you see more gravity gradient, that means worse endothelial injury. So the non-ultrasound and the other image method like chest CT and the chest X-ray is more valuable for us to recognize and realize the endothelial injury and realize the fluid linkage. But we should be cautioned that the epithelial injury happened firstly and last the whole course. And the hypervolemia aggravates the leakage and accelerates more fluid maldistribution. So we could see such researches tell us the result that daily fluid balance is a key factor that to improve the outcome of ARDS patient. So also, if we face a COVID-19 patient, if we found the linkage happened, we should pay more attention to the daily fluid balance. Do not give the patient an extra fluid to increase, maybe that will increase the occurrence of ARDS. But we should be cautious that if we do the negative fluid balance, their patient is in the risk of shock, and we should keep enough volume to make the kidney and other organ got enough flow. That should be emphasized. So, as the first part, we talked about the result and the volume management. We should avoid the volume disturbance and do not give extra fluid to increase the positive balance of fluid, and be cautious to avoid the hypovolemia. And now we'll go to the second part. It's about the cardiac dysfunction of COVID-19. As we know, the cardiac dysfunction is common in the COVID-19 patient. There are different types. There are the compromised RV, or the dysfunction of the left ventricle, including the systolic dysfunction or diastolic dysfunction. Firstly, the systolic dysfunction is we see in the COVID-19 patient. With the help of the echo, we can easily find if the patient got systolic dysfunction, and we can distinguish the types of the dysfunction. This video shows you there's a diffused depression of the left ventricle, and this picture and this video show you that there's a regional hypokinetics of the left ventricle. The systolic dysfunction found in the COVID-19 patient may be caused by many reasons. And the stress cardiomyopathy is also could be seen. The venous attack, we do not have enough evidence, but it may be happen. And this where hypoxia may be the main cause of the systolic dysfunction. And the cytokine storm will be another cause of the systolic dysfunction. And in the later case, in later stage of the treatment, as a patient got sepsis or the septic cardiomyopathy, maybe the cause of the systolic dysfunction. We should be cautious that the pre-existing chronic systolic dysfunction is also found in the COVID-19 patient. And as the disease progressed, another problem we have to face is the ACP. We all know the damage it happened to the lung, and the damage itself can cause the vascular vasculature broken, and other factors such as hypoxia, hypercarbia, and edema. All the settings of the ventilator could increase the time of the pulmonary vasculature that caused the pulmonary hypertension. And the pulmonary hypertension works as an afterload of the right ventricle, which makes the depression of the right ventricle. Unfortunately, in the late stage biopsy of COVID-19 patients, we found a heavy damage in the lung, including the vasculature and the other tissues of the lung. Also, we found other pathophysiology changes that may increase the pressure of the pulmonary vasculature. And the increased pulmonary hypertension damaged the right heart to cause the ACP. With the help of echo, we can easily diagnose the ACP and to evaluate the extent of the ACP and to evaluate the consequence of ACP. We see an enlarged right ventricle and a fractured septum of the heart. Not only the pulmonary hypertension, but also other factors, including the fluid administration or the other factors, may also contribute to increase the depression of the right ventricle and accelerate the degree of the dysfunction of the right heart. One of the key consequences are high CVP that caused by ACP. The higher CVP value can decrease the flow of the kidney and cause the acute kidney injury. As we see from this video, we can see a lower CVP. Under a lower CVP, the flow of the kidney is good, and under the same mean artery pressure, our increased CVP caused the flow of the kidney decrease. So we should pay more attention to adjust the CVP, to lower the CVP, and we should make sure our lower CVP do not lead to the circulation collapse. The second important consequence of ACP is the depression to the left ventricle. We all know enlarged right ventricle can press the left heart, and the left heart could be depressed, and the dysfunction of left heart happened. So we should pay more attention. So monitoring and management of ACPs are very important. Firstly, we should do dynamic echo monitoring to find the onset of the ACP as early as possible, and we should evaluate the severity of ACP and lead us to do careful treatment. The management of ACP, including such as the setting of the ventilator to improve the hypoxia and to do the fluid removing under fluid overload condition or others. And the key treatment is the prone positioning under our ARDS patient. We all know, we all very familiar with the prone position treatment. Other research told us if we do prone position to our central patient, and the mismatch of the air and the flow of the lung were improved, and the afterload of the right ventricle decreased, and we can see an improvement of the right ventricle. So here is a summary of the strategy for ARDS mimics. Also, the strategy is very useful for us to treat a COVID-19 patient in intensive care unit. We summarize it as 3P CVP, that is protection of the circulation, protective ventilation, or prone positioning. The factors were listed in this slide, and we should pay more attention and do it better. Then we go to diastolic dysfunction. The left aorta is most important as it's a stop of pulmonary flow, and if our high pressure of left aorta can aggravate the lung leakage and worsen the pulmonary hypertension. So we should pay more attention to the diastolic dysfunction. How the diastolic dysfunction happened, we do not have enough evidence about the virus attack to the heart. Although we found the virus in the mechanical muscles in the biopsy of the patient, but we should pay more attention to the patient with pre-existed chronic diastolic dysfunction, especially in the elderly patient. And we should control the increased heart rate and do not give fluid to cause to resulting a fluid overload that may cause the diastolic dysfunction be worsened. Also, our decreased systolic function may increase the severity of this diastolic dysfunction. So we should improve the systolic dysfunction to improve the diastolic dysfunction. Now we'll go to another hemodynamic disorder, that is tissue perfusion deterioration. Shock. Shock is a severe hemodynamic disorder, and it's happened to the critically ill patient and is commonly seen in COVID-19 patients in the later stage in intensive care unit. And shock is a hemodynamic syndrome caused by clinical disease, and it could be worsening independent of origin disease. But fortunately, there's a rare shock in early stage in COVID-19. But we see it's usually the blood pressure drops after the patient is intubated and be given deep sedation. So we should be cautious before the intubation and before we order the sedation. But if the patient progressed to the later stage and being admitted to intensive care unit, we found shock is usually seen in some condition. And there are many types of shock we're seeing. And septic shock is most commonly seen in intensive care units. When we facing a patient shock, we'll talk about how we treat the shock patient. Dr. Vincent and other colleagues gave us 4 phases in the treatment of shock. They divide the course of shock into the salvage phase, optimization phase, and stabilization phase, and the escalation phase. We'll talk about the optimization phase, how we treat the patient and optimize the perfusion. The 5P theory is valuable guidance for the internists to optimize the perfusion and to give the high quality treatment to shock patient. We'll introduce the 5P theory soon. At first, we'll review the basics of hemodynamic first aid. Tissue perfusion is a key point that we should pay more attention. So the first P will start from perfusion. You should test the lactate and do other assessment of the tissue perfusion to realize the patient be worsening in the tissue perfusion. Then we go to the second P is pressure. The pressure is a key point that drive enough flow to the tissue. So the pressure is the first treatment we should perform. We use the vasoactive drugs to increase the pressure and to fulfill the perfusion of the tissue. And as we all very familiar with the drugs, we do not spend much time this moment. But you should be cautioned that a high pressure do not often mean that the microcirculation is enough. We could see in some cases the lactate is high in under very high pressure. That means the BP and the microcirculation is uncoupling. So under these conditions, we should think about if the cardiac output is enough in such a condition. So when we face a patient with good blood pressure and bad tissue perfusion, the cardiac output is need to be assessed carefully, and the measures to increase the cardiac output is very important and should be put on the table. We have many inotropic agents listed in this table, and we do not spend time to explain the drugs, as you all know the drugs and do it well. The fluid responsiveness is always a key topic when we talk about increasing the cardiac output. We use many tools and many measures to evaluate, to assess the fluid responsiveness. As we all know, if the patient have the if the patient needs fluid administration, the fluid resuscitation should be performed immediately, as we all know. But if we doing the fluid resuscitation, we should be cautioned that the fluid administration could lead the hypovolemia and cause the fluid overload, and the fluid overload could lead the increase of the CVP value and worsen the pulmonary edema and increase the PAWP. So the fourth P is the two index that is including the CVP and the PAWP that we should pay more attention when we do the fluid resuscitation or management of the fluid. And at this time, the critical care ultrasound is very valuable. We use critical care ultrasound to monitoring the B lines of the lung to know the severity of the lung edema and to know the changes of the lung, the changes of the degree of the lung edema, and to assess the diameter and the shape of the IVC to pause the fluid resuscitation and do more to improve the pressure of the left aorta and the right heart, then to recheck if the patient needs more fluid and how we administrate the fluid. Also, the CVP is a very useful marker that we assess the risk of the abdominal organ, that if the organ is under hyperperfusion or under hypoperfusion, and we will know the risk of the injury of the abdominal organ. At this time, we may talk again that the critical care ultrasound is very, very important. Under the reaction of the hypoxia and the inflammation, or under the stress of the COVID-19 patient, the heart is often being hypercanic. So the hyperperfusion of the lung may increase the lung edema, and the stress of the whole body can largely increase the oxygen consumption. So we should calm down the body and decrease the stress. And the pulse is a very useful marker for us to assess the heart and the stress. So we should control the pulse and to calm down the heart, calm down the body, to decrease the stress. This picture listed the factors that increase the oxygen consumption that we may pay more attention. So in summary, the 5P theory is very valuable for us to optimize the patient under shock and to get the high quality treatment to cure the patient under shock. And we'll introduce the patient class workflow that including the pathophysiological treatment and etiology treatment of shock, and cover the whole course of shock, including the salvage, the optimization phase, and the de-escalation phase of shock. We do not spend much time to introduce this, as you can get more information from the paper. We'll emphasize that the base of the workflow is the examination of the critical care ultrasound. So we'll go to the examination of critical care ultrasound. As we all know, the critical care ultrasound is not only an ultrasound to give you the image of the organ, but also give you more information about the function and the pathophysiology of the organ and the tissue. So This is a modified CCUE protocol. We recommend to you to do the hemodynamic examination that include the 5 views of the heart and the 4 points of the lung each. The 5 views include the anosternal long axis and short axis and apical four chamber and subcostal four chamber and the long axis of the IVC. And the 4 point we do to the each lung include the upper blue point and the M point and the plus point and so on. We get the views of such point or such part to gather more information about the structure, the function, the flow, and the size of the non-ultrasound to assess the air and the water match of the lung, and then we assess the hemodynamic according the approach that we recommend. We call the approach standard hemodynamic assessment approach. There are 6 steps. Firstly is about the premorbid heart function, and we should assess the general changes. And second, we should assess IVC and vital status. And third, we should assess right ventricle, the function and the structure. And fourth, we will assess the left ventricle to know the diastolic function and the systolic function. And the fifth, we will to evaluate the ultrasound of the patient. And the sixth, we should evaluate the tissue perfusion and the non-edema. This is a 6-step approach. With a 6-step approach, we can know more about the hemodynamic changes. Then we can give acute treatment to the patient. Now we'll talk about the first step to know the heart function and obvious abnormality of the patient. We do eyeballing to the heart to do the early detection of premorbid heart disease. We will evaluate the chamber, the wall of the heart, and the valve of the heart. We should know that the right ventricle is the only ventricle that can enlarge acutely, and if any enlargement of the other ventricle happened, we should deduce that the patient is under a chronic condition, chronic disease of the heart. Also, the wall of the ventricle is very important. If the wall is thickened, the chronic pressure overload is found in such patient. And the change of the shock of the chamber may be very useful for us to assess the patient's basic chronic disease. As we see in these videos, there's an enlarged left ventricle and enlarged left aorta, and we see the thickening left ventricle wall, and we see the enlargement of the left aorta, and we see the thickening of the right ventricular wall. This may all indicate that the patient is under chronic heart disease, and if such patient got COVID-19, you can know the risk before the patient admit to before the patient become severe. In such a patient, you can imagine that the patient is under a high risk of pulmonary edema because the enlargement of the left aorta, right? And also the thickening of the left ventricular wall may indicate that the patient is getting a diastolic dysfunction, that maybe the left aorta pressure is high and the patient is in a high risk of lung edema. And the next step, we go to IVC assessment. We will assess the diameter of IVC and at the end of expiration, and we see the respiratory IVC variation to assess the fluid responsiveness. And we see in a collapsed IVC usually indicate that the patient is under hypovolemia, and if the patient got shock, then the fluid resuscitation may be administered. And a small hyperconic left heart or a small hyperconic heart may be another sign to confirm that the patient got hypovolemia, and to get more fluid under the condition that the shock happened. And the dilated IVC or enlarged fixed IVC often means that the patient is under fluid overload of the right heart or fluid overload of the whole heart. So when we face a fixed IVC, we should go to the right heart assessment to know if a patient is fluid overload of the right heart or fluid overload of the whole heart. In a patient with a medium state of IVC, we should assess the respiratory variation of IVC to judge the patient if the patient is fluid responsiveness. Also, we can use other dynamic hemodynamic parameters related to the blood flow to help us to do the judgment of fluid responsiveness. This table, this picture listed the method that we do to do the volume responsiveness assessment, we can pay attention to remember such methods. Then the third step, we go to cardiac assessment. We assess the heart from the right to the left, just as the blood flows. So the right heart is firstly assessed when we're doing the cardiac assessment, and then left diastolic dysfunction, and then left systolic dysfunction is assessed when we face a patient. So when we assess the right ventricle, there's three factors we should remember. The first is the size of the right ventricle. The size of the right ventricle is very, very important because of the feature of the right ventricle. If the pulmonary hypertension occurs, the right ventricle could be enlarged, cause the thin wall thickness. So we assess the size to know if the right ventricle is dysfunction, and we assess the septum to confirm that the right ventricle is dysfunction, and to know the extent of the dysfunction, to know the severity of the dysfunction. If the D sign were found, we'll know that the dysfunction is very, very severe. And we will assess the motion of the free wall of the right ventricle as a third step to assess the right ventricle. And there are two additional factors we should assess is the size of right atrium and the thickness of right ventricle wall. That may be helpful for us to judge if the patient is acute or chronic dysfunction of right ventricle. Then we go to the left ventricle function assessment. We usually use eyeballing to assess the left ventricle. We assess the structure, assess the function, and we assess the flow of the left ventricle to get more information about the left ventricle. The diastolic dysfunction is firstly assessed, and the left atrium is a key part to assess if the patient got a bad diastolic dysfunction. If enlarged left atrium is found, that means the patient is got a very bad diastolic dysfunction, and the patient may be in a high risk of lung edema. If the patient has got COVID-19, we'll pay more attention to control the heart rate and pay more attention to manage the fluid and avoid the fluid overload. Then we will talk about the estimation of the left ventricle systolic function. We also use eyeballing to estimate the left ventricle systolic function. We'll assess the degree of the dysfunction of the left ventricle, and will assess the type of the dysfunction of the left ventricle to know if the patient is diffused, depressed, or the patient got regional hypocanic movement of the left wall that may caused by the stress or the coronary artery disease. These pictures show you different kinds of stress cardiomyopathy. When we performing the critical care ultrasound, we should pay more attention to realize the different kinds of stress cardiomyopathy. And the fifth step will assess the afterload of the patient. If the patient is under the condition that he got a normal anemia and the normal heart function, we can conclude that if the patient is under shock, we can conclude that the patient is under decreased arterial tone, and we call the patient is decreased systemic resistance. And the third step will do the assessment of the lung and the kidney, as the two organs is a marker that to assess the risk of the or the negative consequence of the hemodynamic treatment. You know, the diffuse B lines found in the non-ultrasound may give you the information that you have to distinguish the patient is getting a non-edema or other disease, just like COVID-19. And the flow of the kidney is a marker that to tell us how the organ perfusion looks like. And this slide is a summarize of the hemodynamic assessment approach. We'll review the sixth step of the standard hemodynamic assessment approach we recommend. Firstly, we will do the assessment of the chronic condition of the heart to know if there's an acute, obviously enlarged right ventricle that caused by the acute factors or chronic disease, and we're to assess the wall seeking or the chamber changing of the heart to know if the patient got other chronic heart disease. The second step, we should assess the warning status by assessing the IVC. We should assess if the patient got acute obviously collapse or obviously dilated and fixed IVC, or in the medium state, we use other method to assess the fluid responsiveness. And the third step will assess the right ventricle from the size or the septum and the motion of the free wall of the right ventricle. And the fourth step will assess the left diastolic dysfunction of the left ventricle to see if there's an enlarged left aorta, or if how the cardiac systolic dysfunction, or if the patient got myocardial hypertrophy, and will assess the degree of the dysfunction of the left ventricle by eyeballing to distinguish the different degree of dysfunction. And we'll assess if the patient is diffuse depression of the systolic function, or if the patient got regional or motion abnormal. That means different kinds of disease that caused such a dysfunction. And the fifth step will assess the vessel tension and the volume, the RV function, and the LV function should be taken in consideration to assess the vessel tension of the patient. And the sixth step, we should do the assessment of the lung and also the assessment of the kidney to assess if there's signs of ANMs, BNMs, or consolidation, to judge the pathophysiology changes of the lung, if the patient got lung edema or others. And we should assess the flows of kidney as a marker that how the other organs get perfused, and if another stage of optimization should be studied. That's the summary of the critical ultrasound examining protocol and the approach that we do to do the standard hemodynamic assessment. That may be very helpful for us to manage the circulation disorder of the patient, especially the patient of COVID-19. That's very important. So at the end of this lecture, we should summarize in the key point as such as: the first, the hemodynamic disorder is common, especially in the later stage in COVID-19, and the management of hemodynamic disorder is equally important. Shock is rare in the early stage, but is commonly seen in the later stage that need intensive care. And the 5P theory and the flow-guided therapy are valuable in the management of circulation disorder. And the critical care ultrasound is valuable in the circulation management in critically ill in COVID-19 patients. I know there's so much information I do not mention, and you are very interested in, and we'll talk about further in other classes or lectures, and we'll summarize our experience and to publish them in papers to share our experience to you. Then we can get more people to win the battle of the COVID-19. Thank you very much.
Hi, everyone. Just now, Professor Yin Wanhong take a good lecture for everyone. Let's say thanks to him and thank you for your effort work. His lectures take a great story about the critical ultrasound and circulatory management for severe and critical COVID-19 patients. I think there's maybe can divide his lecture can divide it into three parts, three important parts. One is according to his lectures, I can learn lots of about the hemodynamic disorders for the COVID-19 patients. Just like the special character is that he take a lot of lectures about pathology and make a decision about just like in the very beginning, in the initial stage, the virus invaded the alveolar and injured and take an injury for the epithelial cell in the alveolar, and the patient's protein and protein exudation and infiltration to the interstitial space and some into the alveolar, and then this patient got severe and severe hypoxemia. So then, in the next stage of the COVID-19 patients, the virus invaded after the virus invaded and injured the epithelial cell of alveolar, and then in the second stage, the patient's capillary cell, just like important cell, endocellular cell, injured very severe, and then water and some blood cell can penetrate into the interstitial space. So he make some very interesting decisions. Just like one is patient lung got more consolidation, more lung consolidation and more gravity dependent consolidation indicate that more fluid leakage. Just like its vision, we have got an important reason that endocellular cell injury is very severe. So more consolidation and more gravity dependent consolidation indicate that more fluid leakage, more endocellular cell injury. It's the first key part. Then the second part, we pay more attention, the emphasis on the cardiac dysfunction from ACP to left ventricle dysfunction, and the key point is ACP, like acute cold pneumonia. So it's very often in severe COVID-19 patients. The second part, it's shock. It's shock. Patient got a shock. Like perfusion is very deterioration, and then he give us two steps. the first step is every doctor, every ICU doctor, every doctors maybe obey the rule 5P, 5P theory, and 5P principle, and then he give a protocol, from the IVC to right ventricle, to left ventricle, and to left ventricle. It's a key protocol. So it's a great lecture. So we also say thanks to him again. Thank you. Then we will take a Q&A time. It's a question and answer time. Maybe the moderator, I invited the Professor Zhu Ran.
Thank you. Thanks for Professor Yin Wenhong's wonderful speech, and thanks for Professor Wang Xiaoting's summary, and thanks for letting me hold this Q&A section. I will pick a couple of questions from our audience, and I will read one by one and ask one of my colleagues to answer it. The first question I picked is, would you use lung ultrasound as a positive standard for COVID-19 if CT is not available? What about Professor Chao?
Okay, I will take this question. As we talked before, ultrasound examination is always just belong to an image part. So if you want to give your patient's diagnosis, you have to think about, I think first is signs, history of the disease, and also the other information from maybe laboratory and the other part. So you can't say, so if the CT scan not available, you just use ultrasound to give this diagnosis. So try to think about this. According to WHO, just published several days ago, recommendations, you see the mild patients, severe cases, and the ARDS. So they just certified this kind of a disease. You use ultrasound from a very mild part. The patients have even no very severe dyspnea and dyspnea or hypoxia and maybe short of breath, only have maybe high fever or something. So in this phase, you don't need to use ultrasound to see the patient's the lung. At that time, maybe you just ask patients, take a rest, drink more water. So I think this part is not very useful. But we focus on that stage. The patient's the image will change along to the disease, just become more worse, more severe. So this part is most important part. If at this time patients don't have the CT scan, the opportunity, they can't reach this, you can use ultrasound. Use this part, you can use, we recommended you use the CCUE protocol. So there's some standard or recommended image criteria here. So first, pleural thickening and different degree of B lines, B7, B3, or even fusion B line. And we also have in the different area. For example, you only have maybe very small part of this, and also patient's condition is more or less okay. Patients don't have a very high fever, low blood pressure, or oxygen situation is okay, and no short of breath. So you only have this image. You don't give too much treatment or intervention. But if patients from this kind of a condition become more severe, the breath rate maybe become more than 30, and SpO2 become lower than maybe 85%. And the other thing is also become worse. You use this and you see the B line from maybe one part to the other part. And also you can see some part is, you can appear some shred signs or even bigger consolidations. So you give this kind of diagnosis. And also, if the patients become more worse or become to the later phase of this disease, patients acquired the hospital-acquired pneumonia or the other disease, combine this disease. So you try to think about the other thing, but you try to imagine that your ultrasound examination as a tool, and also this kind of tool can base you more closer to your patients. You can use it every time when you need to gather patients' information and to help your patients. So if you have time, you can read our recommendations. We also have the English version in nearly days. So you can see that. So I think these were my ideas.
Thank you, Professor Chow. I think we only have 4 minutes left, so I will pick up another question about, we have seen this question for several times, so let's answer it. What's the place of ultrasound for early screening in severe versus non-severe patients? How about Professor Wang Xiaoqing?
Okay, it's a good question. Because COVID-19 patients become from mild to severe, maybe to critical. There's a classical manifestation, just like including one is respiratory failure, and then second one is hemodynamic failure. Combined respiratory failure and hemodynamic failure, patient got a critical level. So in every time when they face the patient, when they think the patient maybe become severe and severe, we make a diagnosis. Respiratory failure and hemodynamic failure is two key points. When we take ultrasound, critical ultrasonography for patients, if patients only have a respiratory failure, you take lung ultrasound and echocardiography for patient. You can see lots of ultrasound image feature and lots of heart disease, heart feature, echo feature. So just like lung image feature, including from patch shadow to the diffuse shadow, and then between and from mild to the severe, you can see lung ultrasound feature from focal to diffuse, and from diffuse B line and from the B7 line to B3 line, and then to B3 fusion line to B line fusion, and then some patients got a consolidation. That's a great feature. So when we take echocardiography for this patients, we can find heart become from and silent to excited heart, and some patients got ACP and got pulmonary hypertension, and then become to severe ACP. So if the patient got hemodynamic failure, just like lots of ICU doctors see, heart change, heart disorder is a mirror of the shock. If the mirror of the shock, maybe the mirror of the hemodynamic failure, you can see lots of special features of heart, just like hypo, and the right ventricle dysfunction, and then left ventricle dysfunction, and then you can divide the hemodynamic disorder and then to the shock. So I will point out how critical ultrasonography is image technique. So whatever. Any one diagnosis will be made by lots of informations, including clinical manifestation, laboratory test, and then image, like longer ultrasound and then CT scan. So especially this patient it's a new onset, and it's a new onset, and it's a mild. He is a mild patient. Longer ultrasound, so is not very sensitive. So maybe CT scan is very important in the very beginning. That's all. Thank you.
Thank you, Xiaoting. I think we need to choose the last question for Professor Yin Wanhong, and here is one on today's topic. How can we quickly know hypervolemia the patient is suffering with critical ultrasound imaging? Is it quantitative method or not? Please.
Well, thank you, Dr. Zhu. And we'll talk about this question. As I told you in the lecture, assessment of IVC is helpful for you to get a quick conclusion if the patient is hypervolemia. Do the assessment with eyeballing, and you found distended IVC or fixed IVC in the long axis, and the shape of the IVC in the short axis looks like a circle. That may indicate the patient is now hypervolemia. And this is a quantitative assessment. And if you choose to measuring the diameter of IVC, it's a quantitative assessment. And there are 2 points I would remind you that always take the right heart function in consideration when you assess the IVC. And the second, if there's a mismatch of the right ventricle and the left ventricle, the IVC is not always indicate the volume overload. And that is another story. Maybe we can talk about it further in the other lecture. So that's my answer.
Thank you, Wan Hong. I think we have to end it today, and actually we have a couple of interesting and meaningful questions left, so maybe we could just put it next week or in the near future. Thank you.
Hi. Because Professor Wan Hong took an excellent lecture for everyone. He shared his experience and synthesized thoughts with each other, with lots of doctors online. So we give a chance to Professor Yin and give some important comments for your lecture today. Thank you.
Thank you, Dr. Wang. And as you have summarized the lecture and did excellent work, I think I do not have another summarize of my lecture. And I will say thanks to everyone, and say thanks to the comrades that fight in Wuhan. We all did our best to save the patient, and I wish the battle would win not soon, and I wish the disease can be controlled, and the patient, more and more patients can recover in a short time. Thank you.
Yeah, every doctors and nurses in Wuhan is a fighter, calm, and maybe we take a great respect for them. And let's all say goodbye to all the friends online.
See you.
Yeah, see you.
See you.
Bye. Bye.